But welcome all navigators to our Navigator Training Focus Series. This 1 hour training will provide CEUs for CADAP and CCAP. So we're always excited to offer that. As you know, California Bridge is a program of Public Health Institute, and we do share all of our information. We have nothing to disclose. We're not selling nothing. We're just giving away free training. And for the best experience today, the number one thing on this list is make sure if you have a question, make sure the box where the chat is, the blue titles, it's addressed to everyone. So that way people know what you're asking. So that's the biggest takeaway from this slide. As you know, I always like to start our trainings, and I've quizzed you at our in-persons and gave away lots of presents for you guys and gifts. Our goal for California Bridge is 24/7 access to high quality treatment in all California hospitals, and I think A minus. I think we got as close to 90% of the hospitals, so we're really proud. But this is what I always ask people for is what is our three pillar process for our CA bridge model? We gave away lots of swag when people answered, what is our bridge model? 3 focuses, you guys. What are they? Low barrier treatment. That's our doctors giving the buprenorphine in the emergency room. The last 2 focuses are connection to care and community. That's you bridging and linking your patients to inpatient, outpatient, or whatever referrals they need, and a culture of harm reduction. That's what your role is too. So that's our 3-prong approach. Very simple, you guys. You know this stuff. And always remember, this always may be a trivia question. So announcements. We have our Navigator Focus series is extended through August. They are all free. We're going to have some great topics such as xylazine, substance use in pregnancy, trauma-informed care, and overdose in August. We also have our Navigator update. Those are 30-minute question and answer sessions. And again, we will have great topics such as fentanyl awareness, integrating into your organization, motivational interviewing. And again, August, remember what's in August? Opioid awareness, right? Overdose. So we'll prep you for that. And last but not least, our Navigator Peer Support. This is a pilot project, and we will be having our Navigator Peer Support April 30th at 3 p.m. So we hope to see you at these events. These are our objectives for our CEUs today. Not going to read them. You guys can read them. It's all about biases and stigma. And I'm going to get started. We have a poll today, so I kind of want to fill you guys out. Aiden, if we could put on the poll. Do you believe your ED has adopted the CA bridge model? Your answer 100%, absolutely everyone is on board. About 75 to 99%, almost everybody. Half of the staff is on board, and less than 50%, you still need help. So there's no wrong answer here. We just kind of want to know and get the feeling of the room of how things are going, because some people have been at their sites for a very long time and they won over everybody. Okay. Some sites maybe lost a navigator and they're restarting their program. So they may have less than 50% because they have to build up their team, right? Their fan club, we call it. So want you to answer this as honestly and open. It's anonymous. We're not taking who's putting what down. We're not taking any votes like that. We just want to know in general, do you believe that your ED, not the whole hospital, but at least the ED has adopted the CA bridge model? And again, be honest, be truthful. We don't care who is answering. We just want the answers. So I'll give it 1 more minute and then we'll close the poll. Righty. Okay, Aiden, can we close the poll? Here we go, you guys. It looks like, oh, I like these answers. You guys are very honest. So I love that. We're at 75 to 99%. 61% said that almost everyone. I think that's a great place to be because if we believed everybody was on board, yeah, we know that that 100% is not. So I love the truthful answers. Half is 22%, and less than 50% is 17%. So we got some good numbers here, you guys. It looks like everybody can get support for getting our model into their into their hospitals and just reducing stigma and biases. That's half the battle. So thank you very much for your answers. So real quickly, my experience with SUD, many of you have heard these stories. If not, I'm going to real briefly tell you, I've been 30 years in healthcare, 25 years as a registered nurse, worked in several settings from ICU to outpatient surgery to leadership. And 25 years, I was very limited with my education and training. I believed that substance use was a moral failing, that it was a personal choice. And I share this with you because there's lots of nurses and staff that had my belief. And so when we're talking about, uh, talking to people, we have so many strategies, but got to be willing and ready. And I think right now, more than ever, with the fentanyl crisis, people want to know more education. So you're coming into this with a great opportunity because you are the one that can be the we always call harm reduction specialists because you're the only one in the hospital that can give this information. And it doesn't mean just because somebody does not know and they're very negative towards your program or use bad, stigmatizing words, they're just not educated. So cut them a little slack. But you know what? Again, when 75 to 99% of the people on board, the rest are going to come on board. So I share that because, again, 5 years ago, I got woke. I got educated that it's a medical condition. And again, 25 years ago, 30 years ago, that was not the case. So there's hope for everybody, even the staff member that is giving you so much resistance. Just remember, just drop little pearls, right? Drop little pearls of wisdom and knowledge. And again, you'll win them over in time, right? You're going to be in that 75 to 99% poll next time. So again, everybody can change, including me, right? So reducing stigma and biases, we're going to talk about some strategies and best practices for role modeling, meeting people where they're at, aligning yourself with key stakeholders in your organization, educate staff members, and create your team. So best practice, we're going to start off first with being a role model. How do you do that? Well, we've got so many tools, you guys, and if you're not taking advantage of them, please do. They're completely free. You can become an expert in harm reduction by completing the National Harm Reduction 3-course bundle. It is on our website. And this provides a certificate and it's great information and it's free if you're in California, and we have that link for you. Do not pay for it. It's completely free. There's also some additional trainings. Aiden found these. They're oldies, but they are goodies. So when you get your post-event email, the links will be on the email. And they're principles of harm reduction services, and stigma reduction for emergency departments. The next best practice is meeting people where they're at. What does that mean? So it means normalize it, make sure that when you're talking to people, explain that we're seeing overdoses and people using fentanyl every day. This is our normal, right? I mean, our clientele is very specialized, but this is what we see and it's happening in our communities. Many patients use drugs like fentanyl. This is not, surprising. It's not shocking. It's in the media. So just normalize it. This is what we do. Acknowledge. I know it can be tough to talk about with a nurse, a doctor, right? But again, just acknowledge. I want you to feel better, right? I want to make sure that I want to help you feel better. This is specifically for a patient. So, you know, trying to destigmatize, but when you're the role model saying these questions and these motivational interviewing, the nurses and the staff are going to notice that you're talking differently, right? Where before people will say, we have frequent flyer. He always comes in, he's drug seeking. One of the things I love to say to the staff is, aren't all the patients coming into the ED drug seeking? They're drug seeking hypertension medicine. They're drug seeking insulin. They're drug seeking pain relief. So, you know, definitely there's other words that we can say and, you know, and ask the question maybe, hey, why do they keep coming in? We must not be doing something right. They keep coming in, right? So again, it's really aligning yourself and talking different and talking to the patient, not at them. When you are that role model, again, people will change how they act, especially around you. And then ask questions all the time. I mean, I'm constantly asking everybody questions, not only the patients, but the doctors and the nurses too. You know, why is it that they keep coming back? You know, do they not have transportation? Do they not have primary care? You know, ask those questions and just normalize it. The next step or the next best practice is align yourself. Recruit people in your department, you guys, to help you decrease the stigma and the biases. There's already nurses and people, staff that truly believe in your cause. Don't go after the ones that are non-believers. I always tell low-hanging fruit. You have supporters, use them first. Charge nurses, supervisors, that's always a great start. Collaborate with the staff that has expressed an interest in your program. Those are some key items for you to remember. Don't go after the naysayers. That's a waste of your time. You want your cheerleaders. And then limit your time with the staff that does not express an interest or just takes up your time that this is, why are you telling me about this program? What is it that you're doing? You know, if you've talked with them before, you know, let them know, hey, I've got patients, I've got to do some education because you're not going away, right? So definitely align yourself with people that like your program and want to help. They're out there, okay? The next best practice is educate. And this is again, recruit your champions to support you and your fan club. Charge nurses, again, they're always great. Collaborate with the staff that has expressed an interest in your program. So again, this is repeating, you know, along with the align yourself, but ask your clinical champion if you could start a Words Matter campaign. You can kind of just print out a sheet and walk around and educate people. Hey, did you guys know? So we really encourage you to look at that. Consider sending out a monthly education email. This month, do you guys know what this month is? It's an awareness month. Put it in the chat. Somebody can put it in the chat. You guys want to see it. What month is it? Alcohol. Thank you, Sabrina. Very important. If you haven't sent out an email, just announce, hey, in honor of Alcohol Awareness Month, you know, use this word instead of alcoholic. Use you may use a person who uses alcohol, correct? So this is your one chance. So these are great when it's an awareness month. This is a great opportunity for you to send a short, quick email or even make a flyer or write it on a whiteboard somewhere. So again, please, you know, do something, even if it's small, right? Something even small as just an email. It speaks miles, okay? And let's see, I think what other consider monthly and work with your education department. They're always having campaigns and ask, hey, just tag along. Hey, can I add this to it? Or can I have some time? You really got to promote yourself, right? That's the hard part is if you're not doing it, nobody else is doing it either. And create your MAP program team. If you are not meeting monthly, every other month, or have an MAT program team meeting, you need to. Ask your champion, ask your supervisor, hey, can we, can I start a MAT program team? What you can do for this, it's real basic. Share your data. This is how many patients we've seen. This is how many we've helped. People love data and they want to know what you're doing in your program. So that's the main focus, just for promoting your team and stimulating the interest. And again, start with your Words Matter campaign, reduce that stigma, and share patient stories. I think that's the #1 thing you can do. It's the last thing on here. And I think this is probably the most important. Doctors and nurses love to hear what happened to the patient. So if you even have a minute and send that doctor or nurse that referred, hey, remember what happened to that patient? Share it with the team. They love success stories. And even if it's not such a success, they love stories and hearing what's going on. We couldn't help them this time, but you know what? I planted the seed and they have my phone number and they're texting me. That's a win in our field. If they're talking to you, that's a win. So real quickly, I just wanted to go over Words Matter. Some of you have asked questions. What are words to avoid? What are terms to use? We have that listed here, and also there will be a reference sheet on the post-event email, but we don't use addict anymore. Lots of people do. And can an addict use the word addict to describe themselves? Type that in the chat. I'm asking you guys questions today. Yeah? Can an addict? Yes. Thank you for answering. An addict can call themselves, and you'll hear some of our navigators with lived experience, and you don't correct them because you know what? They have that lived experience and that's who they are. But as a medical professional, we know to use person first language. They are a person who uses alcohol. They are a person who uses fentanyl. And so we should act accordingly and use that. And again, you're the role model. When you start changing and saying these words, they're going to mimic and definitely follow your lead. The other one is substance abuser. I hate substance abuse. We do not say sugar abuse. We do not say fast food abuse. So why would we say substance abuse? They are a person who uses whatever substance. An alcoholic, you can use a person in recovery, right? That's, definitely more, just sounds better. And again, a person in recovery can call themselves an alcoholic. They can use those words, and not us as working in the healthcare system. Addicted baby, that's another one. I crack baby, addicted baby. Nothing breaks my heart more than when people who say that. They may have a condition, and babies cannot be born with addiction because it is a behavioral disorder. They are simply born manifesting a withdrawal symptom. Okay, so using first person language can reduce that. They are a baby with neonatal opioid withdrawal or neonatal abstinence syndrome. We need to use the right words. And again, you're the role model for this. So let's just stop with those addicted baby, crack babies, all of those words. I did meet a gentleman who told me he was a crack baby. And I said, oh, I just don't like that word. It hurts me. And he says, well, that's what I grew up with. And, he didn't realize, that's all he had heard as he grew up. And again, was that stigmatizing? Absolutely. So, you know what? Definitely, if you don't know what to say, ask them, hey, well, what do you refer? Again, just say, hey, I don't use that word. I'm sorry, but, I just can't use that word. So definitely talk with your patients, ask them if it's okay, or say, I don't use the word addict. We're in a healthcare environment, and they'll respect you for that. Definitely, I've had patients, thank you for treating me this way, right? I'm sure you guys have heard that already. And that's all I have to say today. I am going to now be quiet because we have our mentors in the room. And I'm going to start with Karina Ramirez. She is our mentor for Orange County. She was in Long Beach and she changed to a new hospital in Orange County. And I would like her to share her story on how she overcame biases and stigma at her facility. Karina?
Hello, everyone. Welcome. So I want to introduce myself. I know Sherry introduced myself already, but I am Karina. I am in Orange County Navigator, been here for 6 months, and was in Long Beach for about 2 years. I want to tell you guys a little story I have lots of stories, but I think this one was real recent where I had a patient come in requesting Suboxone. I was told by the triage nurse the patient was coming in to requesting Suboxone. So I seen the patient. I had a consult with him. He had been on Suboxone before. He shared it worked for him and he was going through active withdrawal. So when I spoke to the doctor to tell him my patient was in the waiting room and he was requesting Suboxone, he's been on it, doctor was like, I'm not going to give your patient no drugs. And I was like, what? He's not trying to get no drugs. This is why he's here. He's trying not to do drugs. This is why he's trying to feel better. He's been on Suboxone. So, I feel bad at the moment when the doctor like came at me strong about that. So I was like, if you don't give him this, I mean, he's just risking to go back to the streets and pick up anything and risking to come back in here for an overdose. And I just walked away, went and check up on my patient because I don't want him to lose patience and leave. And I told him, I'm working on this. I'm gonna link you to a mat services clinic. So when you leave from here, you're connected. I'll make sure the doctor gives you a prescription. So I was working on an appointment to follow up for mat services after his discharge. So when I went to go talk to the doctor, I guess he thought about when I told him, he's risking to go back out on the streets and overdose. He was like, "Oh, you could sit your patient right here in front." So he was ready to see him. And just being an advocate for the patients and letting them know, his doctor, I'm sure he had a bias, but I feel like now when he probably runs into another patient that would click in his head, he's could go back in the streets and overdose, picking something up. He's not asking for any drugs. So just, you know, not being scared to defend kind of like your patients, being there for them. And yeah, just basically, I've have lots of stories where I had to tell, the doctor and the nurses, hey, like he's just a regular patient, just like the other ones. There's no difference because they're, have issues with substance use or any of that. And well, yeah, that's my story. And I'm sure you guys can also advocate for your patients. And it might get hard at sometimes. I know there's doctors, but always go to your clinical champion, ask them to be behind you and help you out.
I love that. Thank you, Karina. Any questions for Karina? She has started worked at 2 programs, and so definitely, do not hesitate to reach out with her because it's something like in the area you're in. It's over. You told me there's so many people that need help, and the staff want to change, and I think it's just a matter of how they need to change, right? When and how. So definitely thank you, Karina. Thank you so much for sharing. Next up is Chaya. Chaya, are you with us?
I'm right here.
You guys know Chaya. I'm going to hand it over to you.
Hi, everyone. As you all know or don't know, I am still a navigator at Fresno Community Hospital, which is in the Central Valley area. It's been 5 years. So I want to share a little story that I had. So when we started the naloxone program a few years back, it was really slow distributing the medication, right? It was just a very slow start. So a few months in, And this is like a year after our program had already started. We applied for the naloxone. A few months in after we got the naloxone, we did a campaign with our police department, and that really got the word out. And then people started coming in more frequently, asking for the naloxone, and that was when I was getting phone calls literally every hour on to go give out a naloxone kit because someone was asking for it. And it just came to the point where I was like with patients and I was getting calls left and right. And I just told my supervisor, this is too much for me. Like, I can't do this. I need some help. Um, Even though when we got the naloxone, we did the education part. We told everyone we have the Narcan. Anyone can come, any staff can come grab it. We told them where it's at, how to sign it out. But like I said, it was slow. So people tend to forget too. Um, so it was happy. That was like it was just really hard for me because I couldn't be at two places at once. So that was really hard. And then we did another push for education again. And the phone call stopped a little bit, slowed down, and our staff was giving it out, right? And then so I have this charge nurse. One of these charge nurses, she's really intimidating, you could say. And if you guys know me, I'm really shy, right? I won't confront people or go up to people if I don't really have to. Um, and she's like Sherry's mentioned at the beginning, she wasn't a supporter right away, so I didn't really focus on her. I focused more on the people on the staff who did support me. But this charge nurse was just someone that I just didn't like talk to or approach if I didn't have to like at all. But one of those days, I went into the office, the supervisor's office, to go check on the Narcan to see if it needed restocked. And she turns around and she's all like, "You're the Narcan girl, right?" I was like, "Oh shit." I was like, "Yeah." Yeah, what can I help you with? She's all like, "Well, because of your Narcan, we start giving it out more now." And I was like, "Oh yeah, I know. Thank you so much for that. Like, thank you for helping me because it's becoming more frequent." And she's all like, "Yeah, well, I had to go give it out to a family member a few days ago, and it was just like it was so heartwarming." And I was like, "What?" And her eyes got really teary, and she was just like, what they shared with me was just like they were just so thankful for us giving out the naloxone, that they were going to pass the word around to like their family members. And it just really touched my heart and reminded me why I wanted to become a nurse. And I was like, "Wow, really?" She's like, and then like she was just like, "Yeah, so thank you so much for that. Like, I really see what you do now." And then like after that, she just became like one of our like biggest supporters for our program. She's awesome. Like the only one, like probably like up to this day, probably one of the nurses that are still there and like still very supportive of our program. So yeah, that's my story I wanted to share. So involving our staff in the program really helped it grow.
I love that, Chaya. How long did it take you, do you think, to win over that nurse?
Oh, I was there for a year already.
A
And I
year, okay. All right, thank you. Because I think some of our navigators may think it came overnight, and
no.
no, it doesn't. You still have the naysayers. So great story, Chaya. Thank you so much for sharing. We have up next, and I'm just um, Latoya Mitchell. You guys know her. You know her very well, and I'm going to hand it off. She's going to share what she did to overcome stigma and biases. Latoya?
Okay, so some of you may have heard this story before. It's actually one of my favorite to share. But when I was still a fairly new navigator, I want to say maybe I had been there about 6 months, but I had a nurse that was often stationed right behind my chair, and I was like right in the middle of the whole like ED pit. And there was a woman who was brought in by ambulance after an overdose. They had reversed the overdose with naloxone in the field. And so when they brought her in, naturally she was, she was going through it. She was feeling pretty sick. She was kind of like jostling everywhere in the gurney. She was yelling quite a bit. Her hair was like, just crazy. And they sit her in one of those chairs, not like a regular hospital bed, but in a chair. They're fairly comfy, but I imagine when you're not feeling good, being in a chair is not that pleasant either. So she's yelling, not being very pleasant. And the nurse that gets assigned to her, because she got sat in her station, the nurse was like rolling her eyes and she was like, oh, great, and saying all kinds of negative stuff about the patient. Sadly, the patient was very close by to where we were sitting, well, where the nurse was standing and I was sitting. So I know the patient could hear, and she was not speaking very low. She had a voice that carried, this nurse. And so she was saying like, I can't stand them, like, good, I'm going to make her wait longer. Because the patient was asking for something to drink. And she was like, I'm going to make her wait longer. Maybe this will teach her a lesson. Maybe next time she won't do this. And I talked with the nurse and I said, that's not necessarily true. Sometimes it takes people multiple attempts to, succeed at their recovery goals. But if you don't mind, I'm free right now, so I can go help her. I can get her some water. And she was like, you would do that? And I said, of course. I'm like available. I don't have anything else important I'm doing. And literally, this is my job. And she was like, well, I don't have the patience for her. And I said, that's okay. I have enough patience for all of us, so I can do it. And she was like, suit yourself, go ahead. She said, but you know what? I work at so many different hospitals. I've worked at so many different hospitals. I'm a travel nurse. She said, I've been in huge metropolitan hospitals, way bigger than this. And she said, you just see it all the time. You get really jaded by it. And, they're not going to change. They're just going to keep doing it. And I said, I understand that your experience, leads to how you feel. My experience has been different. So, and I have like all the patience and the compassion and whatnot. I have free time. So like you take care of other stuff, you take care of any other patients that, have a higher level of need, and I'll take care of this one. So I go over to the patient, I get her taken care of with a warm blanket, water, ice chips, like the whole thing. I get her connected to care. She was able to start beep right then and there in the hospital. And then afterwards, I go to the nurse and I was like, all right, here's where I have her connected to. Doctor is putting in, dose orders so that she could get her medication. And, the way that buprenorphine works. And I kind of went into like a little bit of that with the nurse because I realized she may not know very much about bup either. And the nurse completely changed and she was just like, oh, well, thank you. And she was like, I'm going to call you every time I have a patient like this that needs your help. And I was like, please do. Absolutely. This is what I'm here for. I live for this. And so that really kind of changed her perspective on things and opened up this door to where she was so ready to, basically refer patients to me and bring me in to collaborate for, patients that maybe needed a little bit more TLC and she just didn't have the bandwidth to give. And so that was back in like 2019. To this day, I'm actually still friends with this nurse. And I just found out that this nurse encountered one of our other mentors at a different hospital. She's still traveling around all kinds of hospitals. And you know, the program and the conversations that we had left a lasting impact on her, and I think honestly has, you know, just a little bit at least changed some of her stigma and bias, and allowed her to at least be open to including other people in that process so that patients can get what they need in the hospital. And that's my story.
Love that. I love how 2019 and come full circle, and we're in 2005 years later, and you're still hearing about this nurse, right? That's a total win, you guys. And it takes time. And I love these stories. Any questions for Latoya, you guys? Any questions for any of our mentors? Okay, no questions. We're gonna go on to the next. Thank you. Wendy, you guys know Wendy. Wendy is our next up. Are you here with us, Wendy?
I sure am.
I'm going to give it to you.
All right. Thank you, Sherry. Hi, everyone. As most of you know, my name is Wendy Martinez. I'm the sun out in the Inland Empire. So I'm going to come in with a different lens on giving you a back end story. So I do want to say that I have had physicians that were not on board, and I've had one specific physician that's so involved with Bridge now. In case you guys ever come across, his name is Dr. Pilar, and he was just fired up about this whole program when I started the program at Arrowhead Regional Medical Center. I'm now at Loma Linda University Medical Center, and there were several times where there was physicians that were unwilling to prescribe or didn't want to be involved in helping our people, our patient population. But later down the road, as I was exiting Arrowhead, one of the physicians there that was super hesitant. This is at the time where everyone was required to have an X waiver. He was able to he got on board. It took him 2 years, but he did. And so that was great. But I want to let you know how I started and where I'm at now as far as being involved with our staff. When I first came to Loma Linda, I introduced myself to anyone and everyone. I used the tool on the California Bridge website. It's the introduction handout. I just put the link in the chat. And I gave it to the information desks in the main hospital. This is a huge campus where I'm at. So for the main hospital where the emergency department was, I made sure that the information booths had my information in case anybody walked in and asked them. I also gave it to our registration clerks in the emergency department, so they would also be aware of what we were going to be starting to do, and also have a phone number to contact me if there were any patients that needed any help right at the moment. Then I met with our ED social workers and familiarized myself with their algorithm so that I wasn't stepping on anyone's toes. And then I also met with the case managers to let them know what I would be doing and like our paths would be crossing as far as getting people into treatment. Midway through, I was able to start an NDB program that took, let's just say I had Narcan on hold here at the hospital for almost 9 months before we were able to give it out, because it had to go through several channels to start that program. But we got it done. I also started to provide like bagels and coffee in the morning for our ED staff. And when I do stuff like that, I hang up signs when where they're being served or serving themselves, so they could kind of read as they go along of my role, or just fun facts, or just information regarding how to treat this patient population. I've also given out trivia candy, meaning I will go to each nurse's pod station and ask the nurse if they know who I am or what I do for my role, and if they can guess it or they want to hear um, about my role, they'll get a candy. And I got that idea from Latoya actually, and it was just one of the best ideas. Um, Another time, I just handed out candy with some fun facts on labels on the candy, and then also with like fun facts regarding bupe induction, such as like not eating or drinking for 30 minutes. Some were just said consult the sun if there's any person with substance use. Um, and now I was able to start a NDP program in our children's emergency department. I have been approved by leadership to do an in-service for our new hire RN so that they're prepared for treating this patient population and have education on buprenorphine. Um, and I have signs that are hung up that are like a facts for RNs, just with questions that I do get for them, like when should I consult you? Just different things. Do I consult you if I consulted the ED clinical therapist, that type of thing. And then I also have signs hanging regarding Suboxone induction. It's called Suboxone induction hot tips for RNs. And it just lists like the no eating or drinking for 30 minutes, what the CAL score should be, all that type of thing on there. And as far as the patient story goes, I have so many, but the one that's sticking out to me right now is a young male. He is 21 years old. He was homeless, and him and his mom were separated at the time just because they couldn't live in the same place together. He was a very handsome boy, and he had told me that 2 years prior, he was on his way to Pepperdine for college, but him and his girlfriend thought they can just use the M30s that they were getting for like a few days here and there, and that they wouldn't become addicted. And they did. And so he came because he realized he needed help, and his mom didn't know. Someone had given him my number, and we text back and forth for about a week before he came in. And I encouraged him to tell his mother because he was going to need a support system, and, let him know that no one's going to love him more than his mom. So she came in with him, and we met, we talked, they cried. I hooked them up with the community health worker to help them with housing once they were discharged. And now I receive updates every couple of weeks, and he's just doing great. They were very appreciative, and he is working, and he is going to try to go back to college soon. So that is my story.
Thank you, Wendy, so much. And I just have a quick question for you. So, how would you say your ED staff, have they adopted the CA Bridge model, and have you overcome
Oh,
stigma and biases?
so one thing I forgot to say is this is ongoing. The stigma is never going to stop. There's new people coming in, there's other people going out, there's people who are not going to get on board. I work at a religious institution, so it's a little more bias here. I've already learned I can't win them all. But at the end of the day, I'm a patient advocate, I'm a change maker, and I'm going to continue to do what needs to be done to support these patients and make sure that they're getting the care they need. And if I can't get it from one physician, I'll go to another, and at the end of the day, I'll call my champion if I need to.
Awesome. I
So-
love that. I love that you say you're the patient advocate and you're still trying to win them over. So thank you. Look at, I'm doing hearts and hearts.
Thank you. Yeah, it's
I've
just,
done
it's an
that.
ongoing thing. It's never going to be 100%, even though I get so frustrated because I want it to be, but
We all do. We
yes,
all want it
yes.
to be
But I just
100%.
do want to let everyone know that this is an ongoing thing. So please don't let it get you down. Just you focus on that patient. So that's the best advice
Wonderful.
that I could give.
Thank you so much, Wendy. I think
You're
that's
welcome.
all righty. Next up is Tommy. And, you know, Tommy was the original navigator, and he had to overcome a lot of bias and stigma being the pilot project and starting this program. So, Tommy, I'm going to hand it off to you.
Hello, everybody. I'm Tommy at UC Davis Medical Center, and I was just listening to everybody with bias and stigma, and I kept thinking that it's still here. I still have it. This August will be 9 years that I've been a son, and I wanted to share a story about a case manager. When I first got here, he's still here also. He told me, he goes, Tommy, I don't believe in what you're doing. He goes, but I like you as a person, so I'll support you when I can. And so, and he does, but up to this day, when we have to ask for permission to pay for somebody's medication, he's one of the persons that always gives us a hard time, man, and refuses. And why do we have to pay for it? And I'm like, either we pay $60, $70 and they go home, or they have to come to ED. It's going to cost us thousands of dollars. So what do you want to do? And so after all these years, a couple of weeks ago, he goes, Tommy, I didn't know Medi-Cal paid for Suboxone. Yeah. So he just like wasn't interested. So I think his stigma and bias is always going to be here. It's not as bad now as it was when I first started working here. When I first started here, I mean, I was called names like you and your family program and all kinds of, I don't want to repeat what they said, but they weren't treating me very friendly, and I had to push back. And I've seen nurses like pull patients off of beds, alcoholics, and get out of here. And I've stuck up for them. Luckily, I haven't been fired. I've been close to it. I thought I was a few times, but I'm not here for anything else but to help people. And if I'm going to get in trouble for it, then okay. And I think that's why I haven't been fired, because I'm always like, it's for the patient. It's not for me. I'm not bragging about myself or anybody else. It's for the patient. And as long as you're doing it for the right reasons, you'll be okay. But I've learned to calm it down and most of the time and just accept it. Sometimes I look around and I just can't believe the bias and the stigma that I see. It's like, man, if just people just aren't getting it. This is a disease. People don't choose to be like that. It's like, man, we're here to help them out. And but I keep going. I keep trying. I'm learning just to turn my head if somebody says something. But like other mentors here shared stories, and I'm sure you guys all seen them, where you're talking to a patient and the curtains close in the room, and you can hear a nurse or someone on the other side going, "Yeah, they're nothing but a drunk," and just like in the patient, you both heard that, and it's like, I get embarrassed, and I apologize to the patient for it, man. I can't believe people are still like that. But I think it's something that we're still gonna deal with always, every day, and expect it, and just keep our guard up and try to learn to be friendly, like some of our mentors, and come back, not if you go F yourself, but like, hey, that wasn't nice, kind of a deal. And I have turned people into their directors and supervisors. And now when they see me, a lot of people, I can tell they don't like me. They look at me, turn around, walk up, and that's okay. I don't care. I'm not here for them. And I was just talking to somebody this morning. When Tommy comes, you learn quickly to turn the other way and take off. But anyway, that's all I got to share. Thank you so much for listening.
Tommy, thank you so much for being truthful and heartfelt. 9 years, you guys, and there's still stigma and biases. So there's no, ultimately, our key takeaways, there is no magic wand. Everybody's not going to love your program, but we keep doing what we do. And I thank all of our mentors because they were the trailblazers. They're constantly dealing with this, and there is nothing that is going to make everybody adopt the program, but you need to keep continuing for your patients and advocate. I love the story about Yvonne. She got invited to speak at the graduating class of residents. That is awesome. And that took you 4.5 years. And you know what? It's a win. So it doesn't matter if it's in 1 year, 2 years, 9 years, you know what? A win is a win, and just keep continuing. We know you're out there. We know you're not alone, because you have all of the people on this call, as well as over 200 hospitals that have this program. So you are not alone. So just continue to advocate and be the role model. And if there's one thing I remind everybody is, can you do just one thing for me? Do me a favor. Don't use substance abuse. Use substance use. If you could just change that one thing for me, that would be so helpful to me. Just start small, you guys. Don't do big projects. Just start small, very simple. It could just be your words or a flyer. So definitely, you've heard from the best. So please take their advice. Do you guys have any other questions for our mentors? This is your time. We have them all here and all together. I think we're still great news, Yvonne. Yeah, I think that's awesome. Wins do not come overnight. Anything else? Tambra, do you want to go off? Can you unmute yourself?
Hi, everybody. That was actually unintended when I put my hand up, so sorry about that. But I did have some interaction this morning with the nurse in the ED. I've been here for over 4 years. She was really aggressive with one of the patients, and not aggressive in just like her words and the way she pulled her arm, the armband off of her, and I didn't say anything. I stepped back and I didn't say anything, but I appreciate the navigators today talking about, just go ahead and be that advocate and go ahead and say what you need to say. Even if I just pull her aside later and say, hey, are you okay? Like, the way you treated the patients was really alarming to me, and just see how that goes.
Yeah, definitely. Because, some people don't even she might not even know. She might be having a bad day. Has everybody had a bad day? I know I have.
Yeah.
And it takes somebody, are you okay? And really, it's showing. Sometimes we just get caught up in the moment. So, definitely, Tamara, thank you for, even though you didn't mean to, I'm glad you said something. Definitely.
Thank you.
Any other questions? All righty, guys. Okay, we're going to continue. If you have anything, you could always go on Slack. Not a problem. I did want to remind everybody before we end, if you have not ordered your free fentanyl test strips, please do so. They will be giving them out until they run out. So it's best if your hospital, of course, with your hospital approval, but let them know. You can always work on a policy to distribute them later, but this is going to be a one-time grant. So please sign up. Any questions about the fentanyl? It's the same application that you use for the naloxone, except it tells you pick. I have ordered these. They have came in, and it was very simple process, you guys, extremely simple. And so they get sent in orders of 500 is the minimum. Any questions about the fentanyl test strips? Go out and apply. We encourage you guys. Any questions, please let us know. As always, we have our bridge tools, so you can go online. and our Bridge Academy for our Sun Training 101. So please use our free trainings, and you do get CEUs for CADAP, not for CCAP. You only get the CCAPs on the ones that are the Navigator Focus series and that are current this year. So again, we're working on things, but definitely we have tons of training. And you can contact us at mentors@cabridge.org. All of our links and all of our supporting resources will be on your post-event email. You'll also have the evaluation to get your CEUs. All right. Anybody else have any questions before we end? Ended a little early. That's quite all right. I'm going to give you a few minutes back to your time. You have at least time to go to the bathroom or grab a snack. All right, everyone. I'll stay around a couple more minutes, and thank you everyone for attending, and thank you to our mentors. They are awesome, and they are always available, and they have so much knowledge. Like I said, I've learned from them ever since I came into this contact with CA Bridge, and they are truly amazing. So I'm glad you guys like this. We haven't had our mentor session for a long time, so I'm really happy they're here. Thank you, everyone. Bye-bye.